Welcome to this edition of Clinical Clips, an accredited continuing education activity. This brief expert video will spotlight the daily hot topics from the conference.
Hi everyone, I'm Vijay Balasubramanian live from ATS 2023 in Washington, D.C. Today is Wednesday, May 24th, the final day of this meeting. Over the last 2 days, I've been able to attend many interesting abstracts and sessions and wish to share some highlights with you. International guidelines recommend the use of parenteral prostacyclin analogs for high-risk patients with pulmonary arterial hypertension. However, these patients are often burdened by multiple complications inherent to parenteral medication. So a very common question that gets asked, can we wean from parenteral therapy? A study was presented by Dr. Budram on transitioning patients with pulmonary arterial hypertension from parenteral prostacyclin to oral Selexipag. As you know, Selexipag was the first prostacyclin receptor agonist introduced in 2015 via the pivotal Griffin study, which demonstrated a significant reduction in the aggregate composite primary outcome of time to clinical worsening when compared to placebo. The objective of the study was to investigate the safety and transitioning from parenteral prostacyclin to oral Selexipag. The study group consisted of 38 patients. 68% successfully transitioned and 32% of patients failed transition. There was no significant difference between the groups when comparing transition protocol or side effects during transition. Elevated NT-proBNP, right atrial pressure, and recent hospitalizations were considered as failure to transition. Higher REVEAL 2.0 composite risk score was significantly associated with failure. So, in carefully selected patients with pulmonary arterial hypertension on parenteral prostacyclin therapies, transition to Selexipag may be a viable option. However, the authors and guidelines recommend that validated risk scores should be incorporated in the clinical decision-making process prior to transition. The next study I want to highlight is the first clinical report in PVDomics. PVDomics, which is Pulmonary Vascular Disease Phenomics, is a precision medicine initiative to characterize pulmonary vascular disease using deep phenotyping. PVDomics tests the hypothesis that integration of clinical metrics with omic measures will enhance understanding of pulmonary vascular disease and facilitate an updated pulmonary vascular disease classification. The purpose of the study was to describe clinical characteristics and transplant-free survival in the PVDomics cohort. The potential to improve the understanding and clinical care of pulmonary vascular disease coupled with advances in translational science led the NIH, or NHLBI, to support PVDomics, a precision medicine initiative to intensively characterize pulmonary hypertension and pulmonary vascular disease utilizing deep clinical phenotyping and comprehensive omics analysis. This approach may refine the traditional WHO Groups 1 to 5 classification by potentially identifying new, more precise phenotypes within pulmonary vascular disease that will enhance scientific understanding and lead to novel targeted therapeutics. PVDomics tests the general hypothesis that integration of clinical metrics with detailed omic measures in the blood will enhance understanding of pulmonary vascular disease, identify cohorts for novel therapies, and potentially facilitate an updated classification scheme for pulmonary vascular disease. PVDomics enrolled almost 1,200 subjects across the spectrum of pulmonary vascular disease, including mild and mixed etiology PH. Key observations were multiple WHO groups were identified in approximately 40% of PH subjects. Diffusion capacity was significantly lower in groups 1 to 3 PH than their comparators. A total of 110 participants had a mean pulmonary arterial pressure of 21 to 24 mm mercury. Transplant-free survival was poorest in group 3 PH. PVDomics will facilitate new understanding of pulmonary vascular disease and hopefully refine the current pulmonary vascular disease classification. The next study I want to highlight is the randomized double-blind placebo-controlled phase 2 clinical trial of anastrozole in patients with PAH receiving background therapy. The study was conducted at 7 centers between 2017 to 2022. People with PAH have higher circulating estradiol levels. Anastrozole is an aromatase inhibitor which decreases estrogen production. Inhibition of aromatase with anastrozole treats pulmonary hypertension in experimental models. 84 postmenopausal women and men with PAH were randomized to anastrozole 1 mg or matching placebo by 1:1 ratio stratified by sex. The study duration was 1 year, The primary outcome was the change in 6-minute walk distance at 6 months. Secondary outcomes were the usual suspects. 41 patients were allocated to placebo and 43 patients were allocated to the anastrozole study group. Both groups were similar in terms of age, sex, and body mass index. The most common type of pulmonary arterial hypertension was idiopathic, and most subjects in both arms were WHO functional class 2. 4 subjects discontinued in the placebo group versus 2 in the anastrozole. 38 subjects in the placebo arm and 41 in the anastrozole arm were analyzed for the primary endpoint. There was no significant change in 6-minute walk distance at 6 months in patients receiving anastrozole. Also, there were no changes in NT-proBNP, echocardiographic parameters, or time to clinical worsening in patients over 1 year. There was no difference in adverse events between the groups. The last poster I want to discuss is Federation. Federation is a global public-private partnership for scientific collaboration across databases in pulmonary hypertension. It aims to facilitate scientific collaboration through evidence generation via a structured network of standardized, real-world PH clinical data. It capitalizes on existing data sources worldwide, such as registries and clinical databases, to enhance the research in PH. The Federation Board is the highest governance and decision-making body with 1 voting representative per database. Each database provider remains in full control over the use and access to their patient-level data to ensure data privacy, ethics, and legal compliance. To harmonize the data, each dataset is transformed into publicly available observational medical outcomes partnership common data model format. This standardization will allow us to conduct analysis efficiently across the network. Identified data partners are invited to participate and develop a common protocol analysis plan to provide aggregated results for meta-analysis, interpretation, and publication. Currently, Federation Network consists of 6 PH-specific data sets with a total of over 12,000 confirmed patients. I'm excited about this initiative, as this data network will enable a global scientific collaboration with strong independent governance processes that ensure fairness, transparency, and robust research. The board looks to expand the breadth and depth of the data to increase diversity and geographic coverage to further improve knowledge of PH. Hope these highlights were informative to all of you as it was to me. Thank you all for joining, and I hope to see you all next year at ATS 2024 on the West Coast.
We hope you found this activity useful and educational. To receive continuing education credit and to download your printable certificate, please return to the activity webpage and click on the Claim Credit button associated with today's clinical clip.